Good evening, everyone. My name is Dr. Deborah Dur. I'm a Program Director of Pediatric Gastroenterology, Pathology and Nutrition at Broward Health in Fort Lauderdale. I'm the current chair of the Nutrition Committee at NASPGHAN. I'm thrilled to welcome you to the second webinar in our exciting new culinary medicine series, Blenderized tube feeding. I am happy to serve you as a moderator this evening along with Sharon Weston. Sharon will be serving as a registered dietitian for the evening presentation. Sharon is a clinical dietitian who specializes in working with pediatric patients and applying culinary medicine in both GI and obesity. We also have a presentation from Dr. Senthil Sankara-Raman. He is a pediatric gastroenterologist in Cleveland, Ohio, and is affiliated with Rainbow Babies and Children's Hospital. Has a special interest in children with nutritional issues, eosinophilic esophagitis, EOE, celiac disease, IBD, fatty liver, and pancreatic disorders. Each webinar series is divided in 3 segments, with a physician educator discussing the topic, followed by a registered dietitian presenting relevant nutritional points related to some diets, and finally a medical chef demonstrating some nice, easy, and fun recipes. I would like to thank NASPGHAN and NASPGHAN Foundation for hosting this webinar. In addition, a special thank to Kate Farms, who supported this webinar through educational grant. Please make a note to join us for the next scheduled webinar in the series, EOE, eosinophilic esophagitis, on December 11 on a Wednesday. We will take your questions at the end of the webinar, but please do not wait until the end to submit them. You may submit your questions at any time during the webinar in the box located directly beneath the webinar player window. Simply scroll down below and you'll see the submission box for the questions. Without further ado, we are excited to begin. Please, Dr. Sankara-Raman, the floor is yours.
Thank you, Dr. Duro, for your kind introduction. These are our disclosures. However, we do not have any financial relationship with any companies or services discussed in this lecture. And so I will start with the medical aspects, what is relevant for a gastroenterologist. My objectives are listed here. I'll start with a brief history of Blenderized tube feeds. I will review its indications and also common prerequisites. I will briefly discuss the benefits of Blenderized tube feeds. And finally, I will also discuss the complications of unsupervised Blenderized tube feeds. It's very fascinating to know the concept of Blenderized tube feeds is not something new. 3,500 years ago, the ancient inscriptions called papyrus does mention that ancient Egyptians and Greeks used a blended form of various dietary therapies, and they administered rectally. The common substances used were like milk, wine, egg, and various grain broths. And this method was popular till in early 1900s. A lot of celebrities and very important people were treated this way. However, there were a lot of experimental tries were done to explore alternate methods of feeding. From 16th century onwards, various forms such as nasal administration, nasopharyngeal, oropharyngeal tubes were all tried with little success or no success. And the major breakthrough was in 1973 by John Hunter, who invented the nasogastric tube, and he used whale bone and eel skin, combination of those, to try nasogastric feeds. And since then, for the past 60, 70, 80 years, fast forward, we have a lot of advancements in the tubes, in gastrostomy techniques, etc. So in the middle of last century, when nasogastric feeds and also gastrostomy feeds were popular, Blenderized tube feeds dominated and was widely prevalent before the introduction of commercial dairy-based formulas. So in 1970s, the commercial formulas came into existence, and whenever it was introduced, there was a big paradigm shift in all the hospital systems from blenderized tube feeds to the commercial dairy-based formulas. And the reasons were listed here. A lot of people thought it was superior because it provided protein of higher biological value. And since the formula was thinner, it was easier to administer. And more importantly, the important reason was less chances for contamination. So a lot of hospital kitchens stopped preparing blenderized tube feeds and started using commercial formulas. And since then, commercial dairy-based formulas dominated the scene. And now for the past 10 to 20 years, blenderized tube feed is regaining popularity. Let's dive into the definition of blenderized tube feeds. Both Aspen as well as NASPGHAN defines blenderized tube feeds as administration of liquidized or blenderized food into an enteral access device, and very commonly we use gastrostomy tube for administration. And also we can broadly classify blenderized feeds into home as well as commercial, even though practically sometimes patients can be on both. And the other common terms we synonymously use for blenderized tube feeds are blended diet, blended formula, or blenderized feeds. And various studies have shown that blenderized tube feed can be successfully utilized in medically complex children, in both in children and also in adults as well. This is a very simple overview for especially for clinicians who are not familiar with home blenderized tube feeds in their practice. So it's not like blending any diet. The family meets with a registered dietitian first, and then after a careful review of medical history as well as the nutritional history, the recipe is specifically formulated for that patient. And family then undergoes extensive teaching about food handling and then how to blend, etc. And the most common method of administration is using syringe. And as I said, gastrostomy is the most common ostomy used for administration of blenderized tube feeds. Coming to the indication, the most common reason or the most common circumstance where blenderized tube feed is initiated is caregiver or parental preference. And a lot of caregivers perceive blenderized tube feeds as being a natural food, and also it's whole food based, and a lot of good ingredients such as antioxidants, it's non-GMO or vegan based on their cultural or family values, their beliefs. They can incorporate varieties of foods also. So rather than just feeding same food again and again, here the caregiver has an option, and also it gives higher satisfaction, and also it gives a good feel to participate in their child's diet. And apart from that, the second reason, which is getting more and more common now, is if patient has allergies or intolerance to conventional polymeric formula. Previously, we always go for a hypoallergenic formula, but now with the popularity of blenderized tube feeds, it is an effective alternate to hypoallergenic formula. Especially if there is denial, if there is insurance denial for the family, rather than buying expensive hypoallergenic formula, blenderized tube feeds provides an effective alternative. And the most important prerequisite is medical stability. The patient has to be medically stable before we initiate this or before we do the transition. And it is not recommended for hospitalized children or acutely ill children. Similarly, patients should have a mature gastrostomy tract, preferably 8 weeks after the surgical placement of a gastrostomy tube, since here the chances of occlusion is higher. So yeah, mature gastrostomy tube is a prerequisite. So coming to the benefits, so this study was done at Cincinnati, and it was published in 2011. Before that, there were a lot of anecdotal experiences as well as subjective surveys from parents about all the benefits of blenderized tube feeds. But this study is a groundbreaking study which objectively showed all the benefits of blenderized tube feeds. Here they chose 33 children who had fundoplication in the past, and all had had severe symptoms after fundoplication, such as gagging, retching, and feeding difficulties. So after discussion with the family, these patients were transitioned to Blenderized tube feeds. And when the symptoms were analyzed after the introduction of Blenderized tube feeds, the results were very impressive. Half the patients had 76 to 100% decrease in gagging. Approximately 3/4 of the children, of the participants, had 50% decrease in symptoms. And interestingly here, even the oral intake, half of them had increase in oral intake. So this study objectively showed that how beneficial Blenderized tube feeds could be in this patient population. Since then, there are a number of studies which again and again shows both subjective as well as objective benefits of Blenderized tube feeds in various patient population. This is a prospective study from Boston where the investigators compared conventional formula with Blenderized tube feed, both home as well as commercial. And here they showed that the Blenderized tube feed cohort had significantly improved GI symptoms. Also, the quality of life for the caregivers and patients improved. And the Blenderized tube feed cohort had decreased healthcare utilization, such as less number of emergency visits, less number of hospital admissions, etc., and also increased patient satisfaction. Then the question comes, what could be the reason, or what could be one of the prime reasons for the benefits of Blenderized tube feeds? One of the important physical property of blended feeds is the viscosity. So the Blenderized tube feeds, because of the increased fiber content, has increased viscosity. This could be one of the reasons for the benefits. And this study, again from Boston group, showed that how viscosity plays an important role. The commercial patients on commercial Blenderized tube feeds were divided into two groups based on how much additional diluent, which is commonly water, is used in most of the patients we use. So here they divided the group into two groups, one with added less percentage of diluent, which is like less than 20% diluent, and they compared with the other group, which has even higher diluent concentration, which is like more than 20%. So the less than 20% diluent the consistency will be thicker. So the other name that they gave is minimally thinned out group, and they compared with the other group. And interestingly, in this retrospective cohort, the minimally thin group, or patients on thicker formula, were less likely to undergo chest X-rays. So the hypothesis here is the thicker the formula means it stays in the stomach longer with less number of respiratory-related decompensations or adverse events, resulting in less need for chest X-rays. And the authors also did multivariable logistic regression to see if there are any confounding factors given the smaller sample size. And here they calculated, or they kind of analyzed other underlying comorbidities such as respiratory status, feeding volume, type of formula, things like that. And even after controlling all these confounding factors, the difference was still significant. And then the next question comes, okay, if the formula is thicker, is it going to affect the gastric emptying? Will there be like gastroparesis or prolonged gastric emptying? So again, from Boston, this group showed that in a retrospective study, Blenderized tube feeds were compared with conventional formula. And for the gastric emptying, they used 1 hour liquid scintigraphy. And interestingly, the Blenderized group received much higher bolus volumes. Here we can see the volumes. The median is 106 versus 66 with a significant p-value. However, when you calculate the number of patients with delayed gastric emptying, there was no difference between the groups. In other words, patients on the Blenderized group were able to tolerate higher volumes with no significant gastroparesis. Here also, they analyzed the type of diet, they analyze the feed volume, and also concurrent use of any medications which can affect motility. And there were no significant difference between the groups. And they did not predict the gastroparesis in this study. Then the next question is, does Blenderized tube feeds or the blenderized diet, does it impact or affect the microbiome, and which results in the beneficial effects? So this study came from Toronto, where 20 children were enrolled when they were transitioned from conventional formula to blenderized feeds. Here, the transition was made mostly due to caregivers' interest. And the investigators, they analyzed both the GI symptoms pre as well as post, and along with it, they also analyzed stool microbiome. The stool microbiome were collected at 6 weeks, 10 weeks, and 22 weeks. And in the clinical parameters, there was significant improvement in vomiting and also decreased acid suppression use in the blenderized when patients were transitioned to blenderized feeds. And also caregiver satisfaction increased, and caregivers said that they will not hesitate to recommend blenderized tube feed to other patient population. And coming to stool microbiome, the dysbiosis was significantly reduced with improvement in bacterial diversity and richness, and also decrease in relative abundance of proteobacteria, which are all indicators for eubiosis. So coming to unsupervised blenderized tube feeds. Luckily, these circumstances are coming down because a lot of clinician champions are advocating for blenderized tube feeds. However, it still happens. So like any enteral feeding, initial consultation and regular follow-up is must in blenderized tube feeds. Especially here, the team captain is a registered dietitian who has interest and expertise in blenderized tube feeds. It is must. If not done, if say like, for example, your family initiates home blenderized tube feeds on their own by talking to another family member who is on blenderized tube feeds, or just referring to social media, things like that, the consequences could be an imbalance in both micro and macronutrients. In the macronutrient, malnutrition is more common and has been reported in prior studies. And in micronutrients, same thing, micronutrient deficiencies or toxicities can also happen. And more importantly, microbial contamination as well as tube occlusions also are possible here. And this risk, as I said, are much more common in home blenderized tube feeds compared to commercial blenderized tube feeds. So ideally, as I said, the family should consult a blenderized tube feed team led by registered dietitians. And the other important team members include gastroenterologists, social worker, nurse coordinators, speech occupational therapists, behavioral psychologists, and clinical pharmacists. And one of my dietitian used to say, as the names, the blenderized tube feeds nicely blends the patient with the caregivers, and also nicely blends all the caregivers. And this is an excellent example of your teamwork. And in the future, we always talk about how one size does not fit all. And we started moving towards precision-based or personalized medicine. And home blenderized tube feed is a perfect way of achieving this goal in nutritional landscape. Thank you.
Thank you, Dr. Sankara Rahman, for that excellent presentation on important medical aspects related to blenderized tube feeding. I am now going to discuss the nutritional aspects related to the use of blenderized tube feeding, and my objectives are going to include describing how to initiate and advance blenderized tube feeding for a patient on a standard formula. I'll also review equipment that's needed for homemade blenderized tube feedings, go over nutritional considerations and administration tips. I'll describe different methods to develop a recipe and how to meet nutritional needs best. I'll compare benefits of homemade versus commercial blenderized tube feedings, describe viscosity of blenderized tube feedings and how to determine that level of thickness using an IDSI test. And then I'll review food safety and monitoring concerns. So first off, there really is no the recipe when we talk about blenderized tube feedings. The recipe is really an evolving diet, and the blend is individual for each child. So how to begin and progress when we have a child or a patient that is on a standard formula. The first thing is really to just start by adding a stage 1 cereal or a stage 1 or 2 baby fruit or vegetable or a puree or a yogurt to that current formula or tube feeding. And we really want to introduce new foods in small volumes that are mixed with that current formula. We can think of percentages of volume. So if you have a 120 ml bolus, taking 10 to 20% of that as a puree that's added to it might be a good way to think about it. Also consider that some of these patients may never have been yet exposed to whole foods. And so trying to treat this as you would treat a child that is being introduced to their first foods right off the bat is going to be similar. It's just going through a tube. So after a child shows that they can tolerate their first foods well, then increase the volume of that puree that's added to a single bolus, or you might increase the number of boluses per day that include that pureed food added to them. One important thing to take into consideration is that a lot of times orders are needed for children or patients to do any modification for a tube feeding. And so you might consider introducing the added purees to feedings that are done at home versus in school, just to make that a little easier to do the transition. As the purees increase in volume, then the calories coming from that base formula will decrease. So keeping track of that balance of nutrients is important to ensure adequacy. And you might want to take into account the minimum volume that formula is providing that meets the goal for vitamin and mineral needs. And once you drop below that volume, then you're going to know that you need to add part of a supplemental vitamin or mineral or both. You also want to take into account free water. So paying attention to as the puree increases or blended food increases and the formula decreases, your free water intake is going to shift. And so you may need to add an extra flush or more than one flush just to make sure that you're staying on top of free water goals. And so utilizing the skills of an experienced dietitian or a healthcare provider that is knowledgeable in blenderized tube feedings is going to really ensure that those macro and micronutrients are met through the transition. Choosing a blender type is another important thing to think about, and this can be really recipe dependent. Blenders can range from standard blenders to immersion blenders to professional strength blenders, and the blenders range in power, but also they range in expense. And so it's important to assess the needs for the patient going on blenderized tube feeding. Is this going to be a short-term thing, or is this going to be a long-term period where they're going to really need to be using this more expensive blender? The lower power blenders are fine to use with recipes that are using purees or baby foods, but really when you consider the physical properties of whole foods that are more textured foods, things like grains and nuts and tougher meat pieces, then you're really going to need a high-powered blender to work best. The length of the time needed to blend can also increase from 3 up to 6 minutes. And so the motor on a cheaper blender is not really going to be able to do that long term. And so again, that's another aspect to think about. You can strain the blend through a strainer, but that can remove particles, but we really don't want to encourage that too much because you're also, when you do that, removing nutritional benefit. So, so just things to think about in terms of blenders. When considering homemade blenderized tube feeding, we also need to take into account a variety of nutrition-related concerns. In general, we want the child to be at least about 12 months of age or older, and also indications for usage should be taken into account to help choose the best regimen to fit the child's needs. We also want to make sure that we take into account what the G-tube size is. We want to also look at ingredient composition and know whether we need to modify ingredients for potential food allergies or intolerances. What is the goal for calories and also for free water? what are the macro and the micronutrient needs and goals. Also, the thickness of the blend or the viscosity of the blend should be taken into account, because this can really relate to the mode of delivery that is used in terms of administering from a pump or by a syringe. We also want to take into account hang times, which can impact feeding schedules. So, for example, are feeds necessary to extend past 2 hours? And in that case, using a homemade blend might not be the best option, since really hang times should be under 2 hours for homemade blends. We also want to take into account, are the caregivers really motivated to do all of the work involved in homemade blenderized tube feeding? So food shopping and cooking and blending and storing. And also, do they have the appropriate facilities to accomplish all these tasks and be able to follow recipes and follow safe food handling guidelines? So there is a lot to consider. Although there is considerable debate regarding the tube size required for administering blenderized tube feedings, the minimum size required will vary between a 10 to a 14 French, depending on the blend. The common reason really is to ensure that we're going to decrease the risk of clogging through an enteral access device. And expert opinion and the ASPGHAN Safe Practices for Enteral Nutrition Therapy guidelines commonly accept a 14 French or greater for patients receiving blenderized tube feeding, although there are definitely reports of minimal clogging with smaller French sizes. It's possible to administer blenderized tube feeds via a J tube as well, but this really needs to be closely reviewed by providers that are experienced in blenderized tube feeding, as there are a different set of parameters to think about when feeding into the small bowel versus the stomach, and all of those things to consider should be things like volume, formula composition, hang time, and osmolality. So how do we administer blenderized tube feedings? Homemade formulas certainly may be more easily delivered by a bolus using a 60 ml syringe rather than a pump or gravity, just because of the relative thickness of the homemade blend. The type of syringe also matters significantly. So the older style 60 ml syringes that have the rubber black gasket in there swells very easily with contact with food-based blends, and it makes it very difficult to push the syringe. But the newer syringes that are the silicone O-ring syringes really do much better in terms of lasting longer and not getting so difficult to push with food-based blend. Also, there are reusable bags that are NFIT compatible that can be used for delivering homemade blends. There are also commercial products now that come in pouches that are compatible with NFIT connecting devices that are very easy to use on the go. Pump delivery volumes is another important aspect to consider in administration, because we know that pump delivery with using food-based blends can differ from actual delivered volumes and can be off by as much as almost 25%. So we want to make sure that we are not just relying on what the pump says is the pump volume delivered, but really thinking about how much volume was poured into the feeding bag, and really making sure that you're ensuring that all of that volume actually got delivered. And finally, paying attention to hang times. So homemade blends are not recommended to hang more than 2 hours. Commercial products that are food-based blends do have longer hang times and are another option. So when we develop a recipe, there are a lot of different ways to come about thinking about developing a recipe for blends. We really want to think first about just general balance with our food groups, and just thinking about the myplate.gov is an easy way to think about all of the important different food groups and how they work together to provide our macronutrients and our micronutrients. But there are also standard recipes that are readily available, that dietitians have created, that are very handy to use. Exchange patterns is another great way to provide recipes to families so that they can swap in and out different foods within food groups using basically the exchange patterns that we used to use for diabetes. And then Also, you can just think of creating recipes meal by meal. So you could have a blend for breakfast and a blend for lunch and a blend for dinner and some snack blends. These could also supplement oral intake as well. When we do develop our recipes, we want to make sure that we're focusing on the macronutrient breakdown. So somewhere between 40 and 55% carbohydrate, 30 to 40% fat, 10 to 20% protein. But again, that can be individualized based on the patient's specific needs. We also want to make sure that we're paying attention to micronutrients. So a nutrient analysis program is very important to use to analyze the recipe and really understand what all of your micronutrients are in that recipe. And finally, paying attention to free water so that we're ensuring that we're meeting hydration needs. So just looking at some sample recipes, we want to first off look at one that is just using baby foods. So this is 1,000-calorie blenderized tube feeding, dairy-free, gluten-free, baby food-based recipe, and very easy for a family to prepare, even using just a regular blender. When you analyze this recipe, it comes out to about 1,000 calories. And one important thing is when we do our recipes, we want to make sure that we pay attention to final volume. The final volume is going to help the dietitian figure out the calories per ml, but also really help us understand what nutrients we're delivering per volume of bolus or feeding. So when you first off prepare a blend, measuring the final volume in the blender, not pouring it out and having some loss on the side of the blender and around the blades is important. So using that final volume that's in the blender is a helpful tip. And the second sample recipe that I want to share is also a 1,000 calorie standard recipe. This is also dairy-free and gluten-free. This includes more whole food. So this is one of those recipes that would really require a more powerful blender. And this recipe is nice just because it's also based off of an exchange pattern list. So again, you could swap out the fruits or the vegetables or the protein or the grains for different versions or varieties, and is going to just provide more dietary variety so that the child or patient does not have the same exact things each day. When you look at the nutrient analysis of this blend, again, it's about 1,000 calories and has a balance of extra fiber coming from all of these whole foods and is going to be well tolerated in general. We also want to pay attention to hydration. So in general, homemade blenderized formulas are about 75% free water. And then we want to pay attention to supplementation. So that's really why a nutrient analysis is very important to do for homemade blends. And even for when using commercial blends, we're going to run a nutrient analysis for our patients. So that way we're looking at not only macronutrient composition, fiber intake, but also really paying attention to the micronutrients and making sure that we're providing adequate amounts. Free water intake is also analyzed and estimated based on that either 75% estimate for homemade blends, or we do have exact free water content of the commercial blends. When we have patients that are receiving lower calorie intakes, often sodium and potassium run a little on the low side, and that is a very easy thing to fix just by adding light salt, which is a combination of sodium chloride and potassium chloride. So some benefits of using homemade blenderized formula are really that, first off, this really allows us to vary the ingredients based on whatever we need to use for this patient. And so, so we can really tailor make this recipe to the individual needs. And we can use ingredients that are commonly in the household and used by other family members, maybe family favorites or ethnic focused foods that are important to the family. And the formula really becomes just like another mouth to feed. It's just going in by a tube instead of by mouth. But there are some benefits to commercial prepared blenderized formula as well. These are really going to provide a simple solution for patients who wish to try a blenderized diet without the need to do all of that food preparation and blending and storing and cleaning up. Blenderized formulas that are commercially prepared are also easier for travel. You can take them on an airplane. They're easier to bring to school because often schools have rules that you're not allowed to bring formula in unopened containers. So that makes bringing homemade blends difficult. And so commercial products can really solve that problem. And then they're handy to use if a child is hospitalized, and a lot of hospitals now have blenderized tube feedings that are commercially prepared on their formularies and can be provided in inpatient. The commercial products also provide a consistent nutrient profile. They have a more consistent viscosity and a longer hang time, up to 12 hours for some of the products, and can actually run by pump as well. And we can use blenderized formulas that are commercially prepared in combination with homemade blended formula. And so you can do both. You can actually even include commercial products in a homemade blend recipe. So there's lots of different options to really take advantage of. Viscosity of blenderized tube feedings is another really important and unique property. And it's really thought that part of the clinical benefit from blenderized tube feedings is just because of that thick formula that really helps reduce gagging and reflux. So blenderized formula, we know, can vary significantly in viscosity based on comparing different homemade recipes and also commercial products. And again, that viscosity change can also impact GI tolerance, and also it can also affect different administration of feeds. So the thinner the viscosity may lose its clinical benefits, but the thinner viscosity may make it easier to administer. We also know that the viscosity of blenderized tube feedings can change just by freezing and thawing, and homemade blends that have been frozen and then tested for viscosity after thawing have been shown to be significantly thinner. So that's an important aspect to consider. Also, there are often families or caregivers that add extra liquid to especially commercial products to just thin it out a little to make it easier to administer. And the volume of that liquid that's needed to add to different commercial products can vary significantly because those different products vary in their viscosity when they're undiluted. The method that's used to add liquids to commercial products also can result in variations in viscosity. So if you add water to a commercial product and stir it in with a fork versus if you add water and put it in a shaker cup and shake it for a minute versus if you add water to a commercial product and put it in a blender for a minute, you may end up with different viscosities. So the method used to add liquid is another important aspect to think about. So it's important to just determine the viscosity, and that can really relate to the choice of delivery through an enteral access device. So the thicker the feeding, again, you're going to probably want to use a syringe versus using a pump. So again, understanding differences in viscosity can help clinicians guide patients to make the best choices to suit their individual needs. And how do we do that? Well, the International Dysphagia Diet Standardization Initiative framework, or the ITSE test, is an easy way to measure viscosity or level of thickness of liquids, and also just different characters of foods. So the ITSE test takes a 10 ml syringe and you pull out the plunger. You have the empty barrel where you stick your thumb on the bottom. You fill it up to 10 mLs with liquid, and then you let it flow out for 10 seconds. Stop it again, and whatever the amount of liquid that is left in the syringe barrel is then compared to this ITSE chart. And then you come up with your ITSE level. So if there's less than 1 ml left in the barrel, that is a thin liquid, and that's a level 0. If there's 1 to 4 mLs left in the barrel, that is a slightly thick liquid, and that is a level 1. Between 4 and 8 mLs is a mildly thick liquid, level 2. Between 8 and 10 mLs is a moderately thick, level 3. And then if nothing has dripped out of the syringe after 10 seconds, that's basically an extremely thick liquid that is also equivalent to a puree. So adding water to blenderized tube feedings, again, this is something that we really want to take caution, and we want to warn our families and patients that thinning may be done, but not too thin is important. So pros of thinning blenderized tube feeding are just, again, to help with administration and provide extra free water. But the cons of thinning blenderized tube feeding are that it may negatively impact that clinical benefit of blenderized tube feedings. And also, it will change the hang time if you're using commercial blenderized tube feedings. So if you have a commercial product that had a hang time of 12 hours, but then you add water to it based on NASPGHAN guidelines, now you've reduced the hang time to 4 hours. So our recommendations really are to start with the smallest amounts of additional free water first and add to that blenderized tube feeding and gradually increase. But again, think about using the smallest amount of extra water that you can so that you don't lose that clinical benefit. And again, pay attention to the method that the water or thin liquid is added. Microbial growth is another important factor to take into consideration when using blenderized tube feedings. And Dr. Teresa Johnson and her team evaluated microbial loads of standard polymeric formulas, and they compared them to blenderized tube feedings made with baby foods and also blenderized tube feedings made with whole foods to compare differences. And what they did was they prepared these formulas in the hospital formula room and then brought them up to an unoccupied patient room, and they tested the samples for Staph aureus and E. coli at time 0, 2 hours, and 4 hours. And what they found was that there was no detectable level of these bacteria at any point, and the total bacterial counts were well below acceptable limits. So it is definitely important that we put our best foot forward, though, and practice our best ways to keep food safe from bacteria. And so keeping kitchen tools and cutting boards and blenders clean, separating our foods so that we're not contaminating our fruits and vegetables with close by raw meat or raw chicken. Also fully cooking things so that we're making sure that things are cooked to the proper temperature. And then finally chilling appropriately, so refrigerating promptly or using within 24 hours and of refrigerated formula, or freezing at 0 degrees and trying to use within 3 months is going to really put our best practice forward. As recommended in the NASPGHAN guidelines, follow-up is also something that's very important with blenderized tube feeding. And so working with the dietitian or nutrition support specialist knowledgeable in blenderized tube feedings is needed really for a successful regimen. Experts in the field recommended initial visits every 1 to 2 months, and then follow-ups can be extended to 4 to 6 months based on the patient's stability after the initiation of blenderized tube feedings. Follow-ups can include assessing anthropometrics and also doing nutrition-focused physical findings exams, including also assessing GI symptoms. Laboratory parameters should be monitored as indicated by nutrition assessment, and any signs or symptoms of nutrition abnormalities or deficiencies that are identified. And specific lab parameters are really individually based on the patient's clinical and nutrition status. Nutrient analysis, also very important to repeat whenever the patient sees a dietitian, just so we have an updated information on macro and micronutrients, as well as free water, and then adjust things as needed with extra supplements or just modifying the foods in the recipes. So in conclusion, blenderized tube feeding can improve clinical outcomes, it can improve the quality of life, and it can meet nutritional needs adequately for our patients. Working with a healthcare provider who is versed in using blenderized tube feeding is important to provide recipes and tips for administration and provide guidance and monitoring for nutritional adequacy. And both homemade and commercially prepared blenderized tube feedings can be used solely or in conjunction to meet the needs of our patients. Thank you.
Thank you, Dr. Sankara Raman and Sharon, for these wonderful presentations. Now, very excited, I want to invite Sharon Weston as a medical chef to demonstrate for us some recipes. Let's start.
Today we're going to be bringing Enteral Nutrition into the kitchen by preparing homemade blenderized tube feedings. We're going to be doing 2 recipes today. The first one is going to be very simple to prepare, and it's going to be based on using mostly baby foods. And this is a great way as an introduction to homemade blenderized tube feedings. This is something that can be an alternative to a commercial product, or it can be done just to try out blenderized tube feedings for enteral nutrition. This is also something that's very handy to do if you don't have a working kitchen and you're on the run or you're in a hotel room, and you can prepare this with a regular blender. Very simple. So we're going to go ahead and get started with this 1,000 calorie recipe for baby food based blenderized tube feedings. We're going to start by adding in 1.5 cups of a pea-based milk. And by the way, this recipe is going to be dairy-free and also gluten-free. We're going to be adding in a little strained chicken, which is baby chicken. We're then going to also add in some strained bananas. These are stage 2 bananas. Also, we're going to be adding in some strained peaches, about half of a jar. And we're going to add in some strained carrots, again, stage 2. Very easy to find in stores. We'll mix in a tablespoon of olive oil, we'll then add in our dairy-free yogurt. I'm using coconut-based yogurt here, plain. We're also going to be adding in some baby oatmeal. This is a great source of iron in a tube feeding. And then to boost the calories, we're also going to be adding in about a half of an avocado that's diced. Again, you could use a regular blender for this. It doesn't need to be high-powered. And we're going to blend this for about 3 minutes. I'm going to stop this in the middle, and I'm just going to scrape down the sides and check how the consistency is. This looks really good. It's really smooth. And one thing to note is that even though this recipe is based on baby foods, it is still nutritionally adequate. It's a balance of all the foods from the major food groups, and it can really still be quite nutritious as a blenderized tube feeding. In general, we're going to try to make sure that we're always going to design our blenderized tube feeding recipes with balance in mind. From all the major food groups, we're going to use myplate.gov or something similar so that we're ensuring that we're meeting all of our macro and micronutrients well. But it is always important to follow up with a dietitian or a professional who's experienced in blenderized tube feedings to ensure that all of the nutrients are met well. All right, so we're going to go ahead and just give this one more final blast. Okay, so we've blended this for almost 3 minutes total. We're going to really try not to lose a lot of the tube feeding that is in the lid, just so that we ensure that we're getting all of the 1,000 calories that were in the recipe into the final volume. Scrape down the sides. And this is perfect. You can see that you end up with a final volume of about 33 ounces. And that is pretty close to what 1 liter is. So 1,000 calories per liter is going to be 1 calorie per ml, and that is just perfect. So very easy recipe. We're also going to just check how you could deliver this using a 60 ml syringe. So just drawing this up, you can see how easy it pushes out. This is an O-ring syringe. And there you go. We have our homemade blenderized tube feeding recipe using baby foods and a simple blender, and we are ready to go. All right, welcome back to the kitchen. We're bringing Enteral Nutrition back into the kitchen with our second recipe now for blenderized tube feedings, and we are going to be preparing a standard 1,000 calorie blenderized tube feeding that is also dairy-free and gluten-free. This is going to be using whole foods, so we are going to be using a professional strength blender here, and we are going to go ahead and mix up our ingredients. It is very important to pay attention to the different ingredients that you use in homemade blenderized tube feedings, because that is really going to help you make your decision on what type of blender to use. It is very important that you have the appropriate blender to mix your ingredients so that you get a smooth final product. So we're going to go ahead and we're going to mix in some peach halves. We're also going to be adding in some green beans. We're going to go ahead and mix in some carrots. And this is really nice because we're adding in a variety of colors, just adding more variety of nutrients in our blend. We're also going to be adding for protein some diced chicken breast. We'll add in our fat next, actually. This is 2 tablespoons of olive oil. And then we're going to be adding in our grain, which is gluten-free oats, uncooked. We'll mix in some starchy vegetables, which are also high in vitamin A, beta-carotene, sweet potatoes. And then we're going to mix in our liquid. This is a pea-based milk. And interestingly, this also has some extra omega-3s added into it. All right, and we're going to go ahead and blend this. Before we start, I just want to also talk a little about food safety. When we're preparing our blenderized tube feedings, we want to make sure that we are really paying attention to food safety. So a clean working area, cutting boards, utensils, all of your bowls, all of your food should be cooked, fully cooked, just like you would be eating it. So we want to make sure that we're always paying attention to food safety when we're creating our blend. Very important, okay? So we're going to go ahead and blend this. It's going to take 3 to 6 minutes, depending on the ingredients and the strength of the blender. And I'm using high. Okay. So it's been about 3 minutes. We're going to go ahead and check our blend. Again, try not to lose what is on the lid, because that's part of your calories. And I'm going to scrape down the sides. And I'm going to inspect my blend. So things to look for are graininess or little small chunks. If you use ingredients that have things like skin of fruits or vegetables or coarser meats, tough chicken, you might notice that there is some graininess. This looks really good, but I'm going to go ahead and just show you what you would do if you noted that there was some graininess. You would use a sieve. And you're just going to pour out your blenderized tube feeding through the sieve, and then it will remove those products that could potentially clog your tube. Before you do that, it is very important to check your final volume again, because that's going to determine your calories per ounce. So this again is very close to 33 ounces, which is almost 1 liter, and that's really perfect for this 1,000 calorie blend. The other thing that is unique about this recipe is that it is also based off of an exchange pattern. And so an exchange pattern helps us to just swap out ingredients for other similar ingredients within a food group. So for example, we could swap out our pear halves or peach halves for berries. We could swap out green beans and carrots for a vegetable medley. We could swap out olive oil for almond butter, or we could swap out sweet potatoes for mashed potatoes. And so it just gives a lot more options for variety. So I'm going to just show you again how you would do this. So I'm going to be using a taller container here. I have my sieve, and basically you're going to pull out your blade, and you're going to, oops, pour your Blenderized tube feeding through your sieve. Make sure that you pour just a little at a time because you don't want that volume to overflow your container. And then you can just use the back of a wooden spoon even and just give it a good stir around so that it comes through. And you're going to just remove all of those difficult fibrous particles. You really want to make sure that you get as much of your blend through your sieve so that you're not losing that nutrition. And some tips to prevent this from happening are especially like if you're using your meats, soft cook your meats so that there's not a lot of graininess left. And also, again, the strength of your blender is really going to impact what is left in terms of particle sizes. So we're going to end up with a nice smooth product here. And to store your products, your blends, you want to really try to either use them within 24 hours or you can freeze them. You can freeze them in containers, you can freeze them in Ziploc bags, which I'll show you in a second. All right, so let's move this out of the way. And you can see here now that you've got a nice, really smooth blend. This is a thin pudding consistency, I would say. Okay. And just for example, this is an example of this exact blend stored in the freezer. To take this out and use it, you would just thaw it in warm water. Or you could just leave it in the refrigerator and let it thaw. But again, you'd want to use it within about 24 hours. Okay. And again, we're next going to really try to make sure that we know the level of thickness of our blend. And so one of the unique ways that we can figure out that level of thickness is by using something called the IDSI test. The IDSI test is something that was founded in 2012. It is a framework that provides us with common terminology to describe food textures and also drink or fluid thicknesses. And it is based on using a flow test. So we're going to be doing an IDSI test here. You're going to need a stopwatch, and you're going to be doing 10 seconds at a time. And what you'll need is a 10 ml syringe. You can use 2 10 ml syringes, or there is actually now an IDSI funnel that you can get from the IDSI.org. And so what you'll be doing is pulling up 10 mLs. You'll have your finger on the bottom of the empty barrel, 10 ml syringe, or the IDSI funnel. You will fill up the funnel to 10 mLs, let it flow for 10 seconds, and then you will stop your finger again and you will measure how much volume is in that funnel. And that determines your level of thickness. So for the IDSI test, you've got a thin liquid, slightly thick liquid, mildly thick liquid, moderately thick liquid, and extremely thick liquid levels. And so if you have less than 1 ml left in your barrel at the end of the flow test, that's a thin liquid. That would be something like milk. If you had a slightly thick liquid, that would be 1 to 4 mLs left in there. That will easily flow through an enteral feeding pump. A mildly thick liquid is going to be from 4 to 8 mLs left in the syringe, and then a moderately thick liquid would be 8 to 10 mLs left in the syringe. Those thicker liquids are going to really help with reducing symptoms such as reflux and retching and gagging. And then an extremely thick liquid would be 10 mLs left. That means nothing dripped out. And then you're at either an extremely thick liquid, which is also the equivalent of a puree. So we're going to go ahead and get started here. I'm going to get my stopwatch ready to go. I'm going to draw up 10 mLs. I'm going to put my finger on the bottom of the empty syringe, fill it up to 10. And then I am going to let it flow. You can see this is quite thick. And really, only one drip is about dripping out here. So I'm going to put this as an extremely thick liquid. And this is something that you could either use with a syringe, and I will show you, if you notice here, you can still draw it up with an O-ring 60 ml syringe. It will still be able to be administered, but it is going to be thick. And this would be more ideal for an individual that had issues with reflux or gagging or retching. If you wanted to thin this, you could add extra liquid, you could add extra water. If you didn't want to add calories, you could add extra dairy-free milk or even juice. If you wanted to add extra calories, blend it again and then remeasure your IDSI test, and then you can just thin that level. So again, we've got here our 1,000-calorie homemade blenderized tube feeding, and very nutritious, balanced, and ready to go for G-tube feedings or enteral feedings.
Thank you, Sharon and Dr. Sakaraman. Was an amazing, comprehensive discussion. And so we have very interesting questions, and we're going to move now to the Q&A portion of the webinar. So the first question I have here is, when transitioning a patient from a standard enteral formula to a commercial prepared blenderized tube feeding formula, how do you decide which product to recommend? Sherry, would you like to take this one?
Sure. I mean, I think that first thing to consider is the age of the patient, so that we're deciding whether we're going to use a pediatric formulation versus an adult formulation. And then also trying to determine whether there's any food allergies or food intolerances or any other ingredients that need to be watched out for. And so I think that one of the things to pay attention to is if you have a child that has never been fed food in that child's life and only has been on standard formula, then it's probably important to trial some foods first. And you can do that easily, just like you would first foods for an infant, by just adding in small amounts of baby food into the standard formula. And again, like what I talked about, maybe 5 or 10% starting. It doesn't really add that many calories, but it really does test that tolerance, just to make sure that when you start to transition to a formula that has food ingredients in it, you feel confident that those food ingredients are not going to be a problem. Most of the commercial products are hypoallergenic, which is great, but you still want to do a little testing of the waters, you know. And then I think that also determining vitamin and mineral needs for that patient is another helpful parameter to look at in terms of determining what product you're going to use, because the different products out there contain different amounts of vitamins and minerals. Some don't have supplementation, some do. And then also think about the mode of delivery. So is it going to be pump versus syringe versus partly orally consumed formula? And how is that administered really determines what viscosity you want to use. Some of the formulas are much thicker than others that are commercial products. Also, some of the commercial products have unique packaging that makes it very easy to connect to a special link adapter that goes right to an NFIT connection. And that's very handy. So if families want that, that would help direct you towards that type of a formula. Also, are there specific viscosity needs for that patient? So does that child have aerodigestive concerns and needs a really thick formula to prevent reflux from below, versus is that child being continuously fed by a pump and needs something that's a little thinner and the hang time needs to be longer? So that's going to direct you in the right formula to choose as well. And then finally, access. So you really need to determine whether their insurance will cover it and whether you have a DME that can provide that specific formula, and that will help also dictate which formula to choose.
Wonderful. The next question I will address here and like send you to take this one. What are some strategies to promote dietary variety in a patient is solely fed, commercially prepared, blenderized feeding as the sole source of nutrition?
I think that's a very important question. So, like again, as we know that we have commercial, we have home, and like most of the families, they prefer home, but not everyone can do. As we know, as we saw, what Sharon did, it's too much labor intensive for, especially for someone who have like more than one child, especially a child with special needs, single mom, working, things like that. So like, but still, it's not like either this or that. Like if they are started on commercial, it again opens another perspective to add foods at the caregiver's space and choice. And again, also, I think that the like evaluating the medical history, any allergies, and then and also the cultural beliefs, differences by the parents. All those things are very important. And again, I think as I said, it's always a joint decision. And I would reach out to my dietitian and then partnering with the patient, kind of like give at least your choices, and then kind of like choose or kind of like in the choice, like which one would be the most appropriate one to begin with, or at least in our mind, which will be more beneficial, things like that. And then slowly, like after tolerance, like we can move on to the next food and go on.
Sure. Sharon, as a dietitian, how you take this question?
I think that variety is something that we always want to promote. Dietary variety, we know that we're always going to meet our nutrient needs best when we have a variety of foods. And so if we're stuck on one blend that we use day in, day in, day without changing, that really restricts our dietary variety. So if you're using a commercial blend, first off, some of the product lines have different varieties within their line. And so you could use a plant and a chicken version, or you could use the different meal versions. And so that would, right away include variety. But if you're on just one specific blend, you can also add variety yourself just by adding different pureed fruits and vegetables, thinking of different colors of fruits and vegetables. Each one gives unique phytochemicals. You can make it easy by just blending one batch, or even just using baby foods and then just freezing them into ice cube trays, and then just pop out a few ice cubes and throw them into a blend. It won't significantly impact the calories, but it will add that variety. And if you are adding more than a small amount of volume and it does impact calories, then working with your dietitian will help create that balance of just how to accommodate for that.
Yeah, absolutely. And we see more and more patients now coming, being hospitalized sometimes and want to use their own formula. So there is a question here about if there is any policies in the hospital, regarding blenderized feed tubing. If you would like to comment, Santil.
So that's a very important practical question. And then I can just, going back 5 to 10 years ago, like both commercial and home, lot of hospitals did not allow. But at least now, majority of the hospitals do allow commercial blended formula. But the unfortunately, the home blended formula, only few hospitals do have. And also, the other important thing is the medical stability of the patient. So definitely the patient is in ICU, and if somebody is sick, then we want to kind of like follow the ICU recommendations as a teamwork. Are they ready? Things like that. That's important. And also medically very fragile population, such as transplant population or immunocompromised population. That's also like it's not a absolute contraindication, but very careful shared decision, especially involving those specialists, is also very, very important. And then the challenge with home, so every hospital, the policies are different. I would encourage viewers to kind of discuss what the hospital policy is. And as I said, majority of the hospitals do not allow, but something like in the future, this is like such a evolving landscape that in the future, who knows, like you may even see that like this come into existence.
Sure. Sharon, thank you. Would like to comment something about using Blenderized feeding with the GJ? That is a question, and this is something that is coming more often now.
Yeah, this is something that I think we all know that there needs more research to be done on to really get a good consensus, but certainly it is being done. And I think that some things to consider first off are you really want to be careful about using homemade non-sterile blends versus commercial products. Also, you don't know what the osmolality is. And so a lot of the commercial products are going to be a safer, I think, choice to start off with. And the viscosity and smoothness of those blends is going to help prevent clogs. Also, the hang time is a consideration when you use J-tube feedings, right? So you're not administering a bolus into especially a smaller child. So J-tube feeds, I think, are something that needs more research. It's something that using commercial products and thinning, or using a standard formula and adding a small amount of a commercial blend to that is something that is possible, but again, needs to have a little more research.
Absolutely. Something very interesting when making your own Blenderized, right? People ask about volume. So what is the total volume in a Blenderized recipe? And there is a way on preparing recipes, seeing the total volume in the blender. So how you discount that?
Yeah. So total volume is a really tricky thing. And it's really important to have that information, especially to provide to the dietitian or the medical provider, because that way you know kind of the calories per ml, right? So if you create a blend and then you dump it into another container, you've lost a lot of the volume that's around the blade. It's very difficult to get that out. So really trying to scrape down the walls as best you can, make sure that all of the blend is not in the lid as well. And then trying to read the final volume when you're it's still in the blender is probably the most helpful information that you can write down when you're creating a blend, especially for the first time.
And would you suggest someone to start doing a recipe, like a physician at home, and then try with the patient, or follow like a standard recipes that are out there?
Again, like Blenderized tube feedings has an infinite amount of recipes, because it's just like eating, except it's going through a tube, right? But you do want to make sure that it's balanced. So using an exchange pattern, or using there's a recipe builder online that you can use from one of the formula companies that's very helpful. You can there's a couple of cookbooks out there now that you can also use and modify that. But again, if you're starting with a brand new blend and you want to provide it to a patient and it's never been made before, I would always say, yeah, just blend it at home or in the kitchen at the hospital, and see how it turns out, and test the IDSI test to see if it's realistic or if it's just extremely thick and is going to need more thin liquid.
Fantastic. Well, I think we can be here all night long discussing. This is so interesting, but just to be respectful also, with we're on top of the hour. It's 9:14, and I really, really would like to thank you, Dr. Sankaraman and Sharon, for this amazing webinar, and all the participants here, and for your time. I would like to thank NASPGHAN and the NASPGHAN Foundation for hosting especially this webinar, and a special thank to Kate Farms, who supported this event through an educational grant. Our next webinar is actually coming now in December. It's going to be eosinophilic esophagitis, December 11, and we have one in Crohn's disease assigned for March 19. I'd like to thank again everyone for your time and commitment with this important webinar, to our audience for participating, and I would ask everyone to please follow the link at the bottom of the player window titled "Click here to return to the NASPGHAN Learning Center" in order to complete an evaluation so we can use the feedback in developing additional educational opportunities. With that, I would say thank you and closure with a wonderful evening for everyone. Thank you until next.